Good evening, everyone. My name is Cassie Chambers. I'm the Operations Director at the South African Depression and Anxiety Group. Thank you for joining us this evening. We're just going to give one more minute to our participants joining us via Zoom. Just as a Zoom etiquette, if everyone can please just remain muted. If you have enough bandwidth, you're welcome to keep your cameras on. It's always nice to see your faces. And you're welcome to just introduce yourself or tell us where you're joining us from in the chat box so that we get to connect a little bit online as well. And to everyone joining us via Facebook, welcome. Good evening from South Africa, and from those that are outside of the country, good morning, good afternoon, and welcome. We'll just give it one more minute and then we'll start the evening.
Oh, that's excellent execution.
Whenever you're ready,
just a reminder to all of our Zoom attendees as well, please make sure that you're muted. Thank you. Just have a couple of more in our waiting room. Fantastic. Well, as we are 4 minutes in, we have a really jam-packed session and a really great conversation, and I want to get started as soon as possible. Just a reminder to everyone, we are recording the session, so it will be made available. That will email you the link by tomorrow. And also, it is streaming at the moment on SADAG's Facebook page. So if you want to share the link afterwards, you're welcome to go to our page at the SADAG, and we'll be able to share that link with everyone and share it with your colleagues and friends, and always go back to it to watch it more. This evening, I have the humble honor of having two amazing speakers join us for a really great conversation around cognitive behavioral therapy. And it's a real honor to have any experts talking on this from the mental health space, but to also have world experts, international cognitive behavioral therapy experts, teachers, ambassadors join us this evening as an NGO, as an organization, and health professionals in South Africa. Is a huge honor as we get more time to actually talk about cognitive behavioral therapy, talk about what it is, what it isn't, how it can help so many different people. And in the space of progressive mental health, this is what makes us really, really excited. So this evening, I'd like to welcome on our panel. I'm just going to add the spotlight to everyone. We have two amazing speakers. I just want to just have to sort. I'm so sorry for all the noise. I'm just going to make sure that everyone is on mute. I know we have our tech support as well, who's helping us with that. So this evening, I'm very, very humbled to introduce our two speakers this evening. We have Dr. Judith Beck, as well as Dr. McGinn, who's joining us from overseas here this evening. And I could probably spend a half of the webinar just going through your amazing CVs and bios. I'm going to have to do a short bio for the time being. Sorry. I think we're just going to ask everyone one last time to please make sure that you're on mute as we do the introductions. We have psychologist and president from the Beck Institute for Cognitive Behavioral Therapy, clinical professor of psychology and psychiatry at the University of Pennsylvania. We have the Dr. Judith Beck joining us, as well as Dr. McGinn. Thank you so much for your time. Again, we'll probably take up 20 minutes just reading your bio, but just understanding that you're a professor at Yeshiva University, co-founder and co-director of Cognitive and Behavioral Consultants, and president of the World Confederation of Cognitive and Behavioral Therapies. Ladies, thank you so, so much for your time this evening here in South Africa and from joining us from around the world. We're really excited to have you and your insights speaking to a wide range of audience. We have counselors and support group leaders and psychologists and doctors and nurses who are joining us this evening. So we're really looking forward to the discussion. Dr. Beck, maybe I can start with you to kickstart the conversation. CBT, cognitive behavioral therapy, and we'll just refer to it throughout the conversation as CBT, has been defined in so many different ways by different people. How would you define CBT?
Well, of course, the type of CBT
that I'm defining is the one that was originated by my father, Aaron Beck, back in the 1960s and 1970s. A number of people defined CBT as a psychotherapy that uses cognitive and behavioral techniques, but that's really not our definition at all, although it is part of it, I guess. My definition of CBT is that it's a psychotherapy that's based on the cognitive model, that the way that people interpret situations is more closely connected to their reactions, their behavioral, physiological, emotional reactions than the situation itself. And we understand that the themes in their automatic thoughts, their perceptions, their interpretations, their themes in these thoughts are linked to the basic way that they see themselves, their worlds, and other people. And we understand why sometimes people have very negative core beliefs. It's as a result of the meanings that they put to usually childhood or early adult experience. It's very negative meanings. Sometimes these experiences are quite traumatic or certainly adverse. And then they cope with them in certain ways that may be helpful or may be unhelpful. The reason that I say that CBT is not defined by its use of cognitive and behavioral techniques is because the way that we teach CBT at the Beck Institute is to do an individual conceptualization for each patient. We never use treatment manuals. So we do an individual conceptualization, we plan treatment based on that conceptualization, and then we integrate techniques from any evidence-based treatment, from dialectical behavior therapy, acceptance and commitment therapy, mindfulness, when we're talking about personality disorders, even psychodynamic psychotherapy. And I could probably list about 10 others. So CBT is defined by its reliance on the theoretical construct, the cognitive model, and is delivered in an individualized and adapted form for each individual based on the conceptualization.
Thank you for that, and a great way to enter the conversation. And my next question is for you, Dr. McGinn. You know, when we're thinking of therapy, and often what the movies and press tell us is that traditional lying on a couch, having a therapist behind a clipboard. And I think one of the exciting ways that CBT really challenges is that it's very evidence-based and very practical. I know this should be a whole separate webinar, but just kind of talking a little bit about what research says about the effectiveness of CBT. Maybe you can comment on that for us.
Sure. I think the umbrella of CBT treatments are not only effective, they've been compared with waitlist, other psychotherapies, comparable in many ways to medication treatments, because even though medications tend to work quicker, they do over the long haul. I think without a doubt, CBT is far more durable. So when you compare CBT to medications, once the medication is over and the CBT treatments are over, it tends to do much, much better. And the thing about it is that it's, and of course, it offers different benefits depending on condition and severity, and the length of time may vary. But the amazing thing about these treatments is that not only are they effective in, managing symptoms, reducing suffering, they also lead to improvement in quality of life. They improve your leisure, your engagement with school, work, health. It allows you to reach your goals. And it can teach you amazing skills, from life skills that you can also use, even if that wasn't part of the impairment you suffered. So it shows that it, improves your decision making, it improves your problem solving, certainly helps you think healthier, take actions that are proactive and face life goals instead of retreating from them. So I would say that over the course of, several years, we have seen this vast accumulated amount of evidence that suggests that it works very effectively and it lasts a long time.
And I think that kind of evidence is really helpful when we're in this changing landscape of mental health, both from a health practitioner, so looking at training and skills that are needed, and really just offering practical tools, speaking from the South African landscape where we don't have years to help someone in a situation, is that we're looking for really practical, empowering skills for so many people who are dealing with so many different struggles. And maybe I can pose this to you as well, Dr. Beck, from all your wide work that you've done around the globe, and especially post-COVID, where we've seen the impact of mental health being such a drastic demand on services and a demand for more help. What have you seen from your own work has led to some of the mental health challenges that we're finding as a society, as a culture, as a globe at the moment, and how CBT could potentially also help mitigate some of those long-term effects?
Yes, so and this actually doesn't have anything, or doesn't have much to do with COVID, but the Surgeon General in the United States has now said that he thinks there should be a warning label on social media for children. And so one of the big trends we're now seeing is an increase in mental health problems that probably were exacerbated by COVID and the isolation that people experienced, but I think had really started well before then. So that's one of the challenges. Something that CBT has to offer is how to coach parents in setting good limits with their children who may be overusing social media, and then developing very poor self-images, poor body images. The amount of bullying that is going on is very, very concerning. So that's just one trend that I see. Another trend that unfortunately is on the rise in the United States is the rate of suicide. More and more people, it seems, are not only experiencing suicidality, but also making attempts. Now, CBT is really quite effective for people who are suicidal. My dad and Greg Brown did a study, I think it was back around 2012 or so, that offered 12 sessions of CBT to people who came to the emergency department at the University of Pennsylvania having made a suicide attempt. And many of these people were homeless, addicted to drugs, had lived in poverty, so that this was a difficult population, but they were able to cut the suicide rate by half. Future suicide attempts by half, which was really amazing. One of the problems we have in the United States is the easy access to guns. And unfortunately, I don't see much of a role for CBT to be able to intervene with that problem.
And I think you raise such an important issue, is that we often have this kind of myth, or now we can call it a myth, or the conception that CBT is most effective for anxiety disorders. But you've just brought up some really key challenges around bullying, self-esteem, even suicide. And I think it helps us to address, thinking of anyone who's joining us this evening who perhaps is a patient or someone thinking of, taking this journey or going to a psychologist who's trained in CBT, but thinking, well, maybe I don't meet that criteria. And Dr. McGinn, maybe from your side, we often think that it's just for anxiety, but it's quite a range of mental health issues that actually CBT can address. And maybe you can unpack that a little bit so that people can also see whether they're a health professional in that space or a potential client thinking CBT is best for me. What does it encompass?
Yeah, I would say it encompasses so many conditions that it would take the entire length of this webinar to go over it. So of course, it is effective for the range of anxiety disorders, obsessive compulsive disorder, post-traumatic stress disorder, schizophrenia. I know obviously Tim and Dr. Beck did a lot of work in that space as well. Eating disorders, childhood problems, bedwetting to ADHD, executive functioning, health issues. It promotes well-being. There's a lot of work in CBT on prevention of illnesses, and that's some of the work that I do. But I think that it's, this started in the US with the APA forming a task force to see what was effective for what condition. And not surprisingly, given the relationship between research and practice in CBT, it comprised of over 90% of the list that they published. And so they're very strict criteria for what makes something effective. And I would say that, if I can't think of anything that has not been on it in terms of mental health. But I think the thing to also remember that it's not just reduces sort of mental health conditions you have, but it also promotes health. So I think it's a lot of work in behavioral medicine in terms of, health problems you might have. It sort of promotes that as well. So I think it's quite a big range.
And I think that's also just so important because it really challenges when to be looking for a CBT therapist, what to expect. And I think, again, for someone dealing with it, looking for answers, looking to work through some issues, or looking to specialize in that field, it's so crucial. And I think we often, again, have to look at our references and our context that we get from movies and shows of what a typical session looks like. What does a typical CBT session look like for you? What could a client expect? What does it look like?
Is that for me or for?
Oh, sorry. Dr. McGinn, we'll start with you and then I'll come through to you, Dr. Beck.
I think, basically when someone comes in, I think what's the beauty of CBT is that it's so individual, meaning that you are talking to the client about what they're going through. You are doing what we call ecological analyses, where you are tracking what's going on in their everyday life so that you get a deep understanding. And I think, what Judy was saying earlier is that you're doing a CBT case conceptualization. So based on the condition that you have, you are sort of understanding the person's internal world, their behaviors, their belief systems, and based on that, that's what I do. So I spend a lot of time with that assessment and case conceptualization. It might involve finding out what happened in somebody's life on a Tuesday afternoon and tracking it and trying to understand what was going through their mind, or how did they feel inside, and what behavioral urges did they have to do at the time, and then how is that perpetuating for them what is going on? Why are these patterns repeating over and over again? That allows you such a clear understanding of the person. And then that becomes a roadmap for me for the rest of treatment to figure out what strategies I should use so that I can treat them. Whether it's panic disorder, could be a complex presenting problem with depression, panic disorder, eating disorders, but that conceptualization then guides what strategies I use.
I love that it's so individual and those different strategies that work for each different person. And, SADAG has always been such huge advocates for CBT. And we even have a lot of our board who are specialized in CBT as well. And I just remember so many practical workshops where we have patients who are totally disabled about the fear of flying, and they can't even think about getting on an airplane. And after a workshop, after 2 or 3 hours, using CBT skills, they're actually excited to go and book a ticket to say, I'm going to try this out. And I think it's that overwhelming sense of empowerment that so many patients are equipped with, that we don't always see in other spaces. And I think it creates such a positive change in how we're addressing our mental health and wanting to tackle it. And maybe Dr. Beck, I can come to you with this question, is that you've just mentioned, Dr. McGinn has spoken about how the sessions work and what they look like and how they're so individualized. And I think a lot of the work also happens in between each session. What kind of homework or coping skills or kind of self-assignments that patients would often get with a CBT trained practitioner?
Sure. So I'm going to go a little bit into the structure of the session to be able to explain that. One of 4 things that we do at the beginning of the session is to set an agenda with the client. What is most important to the client to talk about this week, either in the form of a problem that the client has had or a goal that the client has for the session or for the upcoming week. There are a number of other things we also tend to do at the beginning of the session. In the middle of the session, we take up the first agenda item, the one that the client feels is the most important, and we collect more information about it. We especially ask questions to fill out the cognitive model. What was the situation either that came up that was so difficult or that you anticipate will come up in the coming week? How do you feel emotionally? What do you do behaviorally? And what automatic thoughts lead you to have this kind of reaction? So we do a mini conceptualization. And then with the client, we collaboratively decide where to start working. So we might work at the situation level, doing some problem solving. We may work at the automatic thought level, either helping clients evaluate and respond to their thoughts in some way, or if it's part of a dysfunctional thought process, such as rumination or obsession or streams of self-critical thoughts, we might use some acceptance and commitment techniques and teach patients how to detach from their thinking in a non-judgmental way. Or we might work to help the client directly reduce the intensity of their emotion, and we might use some techniques from dialectical behavior therapy to do that. Or if they're having a physiological response, we might use some techniques from behavior therapy like progressive muscle relaxation, or we might concentrate on the patient's behavior and do some skills training about that, maybe if it's interpersonal, doing some role playing. So we conceptualize the problem or the goal in terms of the cognitive model, and then we collaboratively decide with the patient where to start working. And we might work at any of those levels that I've just said, or we might work at 2 or 3 of the levels. It all depends on the patient's response and what seems to be helping. Before we move on to a second agenda item, we say to the client, what do you want to remember that we just talked about? And if they come out with a pretty good summary, we'll say, yeah, that sounds good. Do you want to write that down, or do you want me to write it down? Research shows that people forget between 40 and 70% of what they hear in a doctor's office. We think they forget up to 90% of what they hear in a therapy office. So our rule of thumb is anything we want patients to remember had better be written down. If their summary isn't that good, we might say, well, I wonder whether it might be more helpful to remember it this way. Frequently, their summary has one important point, but there may be some others, and so then we might offer, do you also want to remember such and such? And if so, then we write it down. And we also make sure, if the client hasn't already said what he wants to do about the problem this week, that we collaboratively decide what that should be. And then here's a really important question. We tell clients that it's really important for them to read these therapy notes every morning, and then they can pull them out throughout the day if they want to, when it seems indicated. So that they get socialized very quickly to the fact that these are really important notes, that you don't just come and to therapy and talk for 45 or 50 minutes, but you're going to learn things at every single session. So we have this nice summary. We have also written down what they're going to do behaviorally, and then we ask the question, how likely are you to read these notes every morning, or how likely are you to call your neighbor and invite her to go for a walk? If they say less than 90%, then we know we have some more work to do. We either have to make the assignment easier or perhaps optional, or we have to find out what might get in the way. So there might be a practical problem, there might be some interfering thoughts, and so forth. So since we make sure the patients don't leave our office until they have this collaboratively set, what we now call the action plan, because people don't like the word homework, and it's written down. And then we make sure to review the homework or the action plan toward the beginning of the next session. And we particularly help clients draw conclusions about their homework completion. So if the woman went for a walk with her neighbor, I might ask, when we we talked about this last week. You weren't 100% sure that you would be able to do that, or that you might be too tired to walk. Is that what happened? And the client says no. And you say, oh, so what does that tell us? Does that say that maybe you can do a little bit more than you think you can? And were you able to give yourself credit for doing that? So that's, I guess, a long-winded way of saying this is what we do to set the action plan, review it, and make it likely that the client will participate in it.
I think it's so structured and there's so many different techniques and tools that come into it. And I could just imagine writing tons and tons of notes and reviewing that and kind of going back to that all the time. And I love that it incorporates so much with the client as well. It's so empowering and there's so much that we can learn from that. And I think also, Dr. Judith Beck, you have done a lot of work and we've seen a lot of articles and you talking a lot around recovery-orientated cognitive therapy. And we've had some questions come up about that. Can you unpack that a little bit for us as well?
Sure. So recovery-oriented cognitive therapy, I'm now going to just call it CTR, was developed by my father and Paul Grant, who's now at the Beck Institute, and other colleagues, as a treatment for people with really serious mental health issues like schizophrenia or bipolar disorder. And they developed it for probably the most difficult patient population, as these are people who have been in a state hospital for maybe 20, 30, or even 40 years. And the staff has completely given up on them. They've also applied it to people with schizophrenia who are homeless or who are incarcerated, or people who are a little less severe, maybe living at home or living in the community with special supports. What's so interesting about this form of this adaptation of CBT is that it really focuses on the positive. So in traditional CBT, we focus more, not exclusively, but more on the psychopathology. What happened in the past week that was so difficult for the patients. And we work directly to reduce their symptoms. But when you do that, you don't necessarily, when you reduce negative, or let's say uncomfortable symptoms, it doesn't necessarily increase positive mood. And I think Dr. McGinn was alluding to this kind of thing a few minutes ago. So what they did in the state hospital was, and people can read about this in Recovery-Oriented Cognitive Therapy for Serious Mental Health Conditions. The first author is my father, Aaron Beck. And I've also applied the principles of CTR to kind of more typical outpatients in the third edition of CBT Basics and Beyond. But the principles are the same. One of the things that is really important, especially in the state hospital, is to find out when the patient is at their best. What are they doing? How are they probably feeling? What are they probably thinking? And then the therapist takes quite a while sometimes, but establishes a rapport with the patient just by engaging in positive experiences together, whatever interests the patient. So it might be playing basketball, it might be going to McDonald's for a hamburger, it might be baking a cake, it might be listening to music together. And over time, what the therapist does is to do something that I gave an example of a few minutes ago, which is to help these individuals see that they really can affect their mood, that they can feel better if they join others in the music group, if they walk outside and really notice nature. And so they are working very directly on helping clients draw positive conclusions from their positive experiences, and that helps them increase the intensity of their positive beliefs. So kind of in a nutshell, that's how it is. With outpatients, we use the same kinds of techniques, and we tend to put the emphasis on the positive, asking people what goal they have for the session or what goals they want in the coming week to achieve in the coming week. helping them draw more positive conclusions. But also, when it comes to doing the action plan, the things that they're going to do in the coming week that are in line with their aspirations and their values, then we find out what challenges might come up, what might get in the way of their being able to do the action plan, and that's when we use more typical CBT techniques.
Which is just so amazing, this practical partnership that you create with clients. It's this back and forth, this workshop. It's really engaging. And we've focused a lot around kind of adults and clients getting really engaged. And Dr. McGinn, from your side, how could CBT be used or should be used for children or even adolescents? How does CBT therapy look like for younger people?
I think that, depending on the age, of course, for adolescents have the capacity to abstract. So it starts to look a little bit more like it does with adults. But there are certainly differences. And the smaller the child, you have CBT therapies like parent-child interaction therapy for 2-year-olds, 3-year-olds, 4-year-olds. So then certainly that is far more behavioral and focused more on sort of engaging the child. But I think adolescence is certainly a very key time, I think, to intervene, because a lot of conditions begin in adolescence. And the research shows that, let's say you get depressed when you're an adolescent, your episodes are worse. You have you're more likely to have recurrence, more severe disability. And so untreated, it can be quite costly. So I think intervening in adolescence, I think it's important, because that's when so many of these begin. So a lot of the work that I've done is looking to help sort of arrest that development. So a lot of prevention in terms of development of depression and anxiety. I've tested it with adults in NIH trials. I'm now using it as a universal tier 1 program. That's what it's called here in the US, which means everybody in the classroom gets it, to prevent anxiety and depression. And that way you're building resilience, you're building functioning. So I think with adolescents, you have to be very real. You're not sort of, in any way, CBT is built that way, that it's so collaborative, as Dr. Beck was saying. But I think that with adolescents, it's even more important to be radically genuine, and that way they feel that the treatment is more real. And the good news is that they respond so well to treatment. And the prevention interventions that are done with this age group show that it has such a big impact on reducing the likelihood that they will have recurrence, that their episodes are less, they're more likely to function better, reach their developmental life goals. That is such a problem around the world, where young adults are not launching now in time. And so I think the more you can give these skills when they're in adolescence, and maybe even younger, that way you're promoting them achieving those developmental life goals.
I love the idea of dealing with the young people in a real and genuine way. And just hearing about the programs you have around including those CBT tools as part of a preventative and awareness campaign in young people, as part of the curriculum, is something we as only South Africa can strive for. So we'll add that to our wish list and come through to you. But we have a question for you as well, Dr. McGinn. We've had it from the audience around kind of the development of this new online AI world and the development of online CBT tools or iCBT. From your experience, what kind of new trends or developments have you seen? How effective are they? And is that the new generation of CBT?
Well, I'll respond to it in a couple of ways. One is that CBT the researchers have been looking at online therapies well before the pandemic. So the good news is we know that it works. So we know that the therapy delivered online by a live therapist. We know that therapy delivered over apps can help. There's a lot of exciting work being done all over the world, a lot of app development in Australia. But the issue is more that the usage of apps tends to drop off. So what tends to happen is that if there's no live sort of coaching, or there's no intervention sort of to help that therapy. Like, Dr. Beck was talking about how much work she does, in terms of making sure the patient follows up with homework, with the action plans. And so what tends to happen is that people take these apps, start doing it. It's effective if they do it. The issue is they are not as likely to do it unless there's a human. So the need for therapists is still very high, despite all the developments. As far as AI, I guess it remains to be seen. I think one of the things our world is struggling with is loneliness. Loneliness has become a pandemic. And so I think to the extent that therapy offers that warmth, that human connection, that I don't think will be replaced. And so you might get it, it has a space in there where it might help in a better way achieve things like in between therapy, what you do. It might allow sort of a better way to sort of lessen the burden of some of the work in CBT. But I don't think that it will replace that connection, that individual connection with the therapist.
And I
I
think
hope
that's
that answers
also,
the question.
it did for me, and I'm asking the audience as well, if they want to add more follow-on questions, they're welcome to post in the chat box or on Facebook. And I think, one of the lessons we've also learned through the COVID pandemic and the before and after and during is we're still humans needing humans. And I think that element is still so true. Dr. Beck, I have a question that follows on from that, from this ICBT, is that I know that your father, Professor Aaron Beck, and you have worked many, many years in the space of CBT and building on many of those foundations. What have you seen has been some of the biggest developments in CBT over the years? And how do you see CBT in the next 10 or 20 years?
So when my father first developed cognitive therapy, he developed it as a treatment for depression. And he had told me that at that time, he didn't predict that cognitive therapy would necessarily be effective for any other disorder. So what we have seen in, since the 1970s on is CBT being applied to more and more disorders. And this is what my father did and really set as a protocol, I think, for other researchers, many of whom he and I trained to conduct research on different disorders. But so the first thing is, it's very important to understand what the disorder is. Let's say it's chronic pain. So we want to find out more about chronic pain. When does it happen? Who does it happen to? Who has chronic pain and yet still has a pretty healthy psychological adjustment to it? Who doesn't? What's different about the people who don't? What are their most central negative beliefs about themselves, their worlds, and their futures that could interfere with helping them not overcome the chronic pain, but adjusting to it better? As a result of listening to patients very carefully, something Dr. McGinn talked about at the beginning of this talk, the researchers will come up with a cognitive formulation of chronic pain and understand what some of the maintaining factors are, understand what the key beliefs are. Then they will come up with a treatment plan that seems to fit this particular formulation. They'll try it out with patients, they'll make adjustments as necessary, and then when they think that it's ready, they'll do some clinical trials, particularly randomized controlled trials, to establish its efficacy. And then one of the things that I do, particularly at the Beck Institute, is disseminate research findings and train therapists in how to make use of the research that has shown that a particular disorder that CBT is effective for. So that's one change over the years, has been its application to many, many different psychiatric disorders, psychological problems, health-related problems, and as Dr. McGinn said before, just difficult difficulties in having a sense of well-being, difficulties in being able to live in alignment with one's values and aspirations. Another change that we have seen in recent years, well, it really started decades ago, was the application of CBT to different settings. So you'll now see CBT being used in schools, in jails and prisons. You'll see it being used in inpatient and outpatient departments. And you'll see it being used by an enormous variety of professionals and paraprofessionals. So including teachers and school counselors, occupational therapists and physical therapists, especially when we're talking about serious mental health issues. The use of peer specialists seems to be especially important. So that's another change. And I'll just mention one more, which is in the delivery system that's being used. So in the United States, we still primarily use individual treatment with many patients, unless it's a specialized setting like a school. But that's just not practical for many places in the world. And hopefully, eventually, we'll get even better at the apps and the computer programs. So less and less therapist time will be needed. But there are three systems I'd just like to talk about very quickly. One was developed by David Clark in the UK, who had spent a year around 1983, I think, with my dad learning about cognitive therapy, and then took it to England. And then in the past few years, developed the IAPT system, IAPT system in England, where patients are identified as having depression or anxiety by their primary care doctor, and then are triaged. So the patients with very mild depression might join a psychoeducation group, for example. Someone with more moderate depression might get behavioral activation, and someone with a very severe or chronic or comorbid depression might be the ones who see someone with a doctoral degree or a medical doctor, psychiatrist for that. So that's one system. Another system is in, oh, now I'm forgetting which African country it is. Maybe some of you know this. I think it's Zimbabwe, and the friendship benches, where they teach some of the, I think, elders in the village, especially the women, to sit on a bench and invite people who, especially young moms, but I think anybody who has depression, to sit on the bench and do some rudimentary problem solving and behavioral activation. And then they encourage them to join some kind of community group. And a third one is in Pakistan, where they have trained lay counselors to work in primary care and have had really excellent results in reducing depression. So, oh, and I want to mention one more thing that's so important, which is adaptations of CBT for different cultures, for different religions, for different nationalities, for different ages. CBT has now been adapted in so many ways. And I think that's incredibly important, because it didn't start out that way. But in the recent 10 years or so, it has really been adapted for many different populations.
I love that it talks so much around building that resilience and adapting and changing and fitting the criteria. And I think as an African perspective as to treating mental health, I think the idea of the friendship bench and just how to train and give skills to teachers and lay counselors just really puts those key skills in the hands of people who really need it. And for us, that's really exciting. And Dr. Beck, I'm going to come back to you, because we've also got another question around how can a therapist or how can therapists get basic or advanced training in CBT? And I know that you focus a lot on this work and do a lot of online, but maybe you can share with some of the different therapists that are joining us online is what does training look like and those different steps?
Well, we have a long history of training at the Beck Institute. In 2 weeks, we're going to have our 30th anniversary from when my dad and I started the Institute, and we've trained about 45,000 people in over 130 countries. Just very proud of that. We were really lucky with COVID, because we had already developed online courses, and now all of our training is virtual. But you don't have to get training through us. I think it's really important to attend conferences as you can. That's why I'm hoping everyone who's watching will come to the South African CBT conference, which is, I know I'm presenting on August 30th. And I know Dr. McGinn is also going to present during that conference too.
Yeah.
It's very important to do that. I really see learning CBT takes a lifetime. I always tell people that I'm a much better therapist today than I was 5 years ago. And a lot of that has to do with adding these recovery-oriented principles to my work. But I find every 5 years, I really kind of make a leap ahead. And I sure hope that I'm a better therapist 5 years from today than I am right now. So I think it really takes a lifetime of learning. It's really important to read the research, and to incorporate new research-based principles and techniques into your work. It's also very important to monitor your patient's progress at every session and to get either consultation or supervision. I think periodically throughout your career is really a good idea. I'm so lucky because at the Beck Institute, we have expert therapists and we have a case conference every other week. And so we all bring up our most difficult clients and get feedback. We have a consultation and also a supervision program at the Beck Institute that can lead to certification if people are interested. Also important just to keep up with the literature. My goodness, I used to be able to do this much more easily than I can now. It seems that every week I think I come across a new CBT oriented book, either for consumers or for professionals. If you're in an area where there aren't a lot of CBT therapists, be bold, be brave, see if you can set up a CBT online kind of group, which might involve reading certain books, certain chapters of books and discussing them, might involve someone's reading research articles and talking about the application to their work, and certainly could involve people presenting their cases and getting feedback from other people. Now, this used to be so much harder to do decades ago, but now, because of the internet, I think these groups can really start to form in many different countries in many different ways.
I love that. And it really challenges our different therapists who have joined us around the country. And I'm so glad as well, Dr. Beck, that you mentioned about the CBTASA Congress that's coming up. And I know that we have our own Judith, our own Daniel, who'll be talking us a little bit more at the end towards around who's at the Congress, where it is, and those details, because it's such an exciting opportunity to continue these conversations and to engage and to learn from each other, and really connect to the South African networks that are there, so that we can see the CBT fraternity really growing and engaging more and keeping up to date, which makes us really excited that we get this opportunity to talk to both of you, and that we get to partner with CBTASA for their Congress, because it's really exciting in our South African landscape to have such amazing experts and conversations, even from internationally and around the globe, but even our South African experts all coming together in one space, talking about these developments and these trainings and sharing the skills. And I think what really gets me excited about this Congress, which is different to perhaps other congresses we've had in the country, is that it's so practical. There's key workshops, and I think that's what's really great, is it's hands-on. You really leave the Congress with all these skills. So I'm definitely, Daniel, I know is waiting in our wings, and we're definitely going to come to him to share all of those details. And we're just getting such amazing questions. And Dr. McGinn, maybe I can come back. I think it ties to some of the comments you were making around working with young people and adolescents. And this is a question from a therapist on how easily do you manage to engage with adolescents? Are they usually very available? Are they open to CBT? What kind of tips and tricks have you worked with engaging with young people?
Yeah, I think that, the when adolescents first come in, it's not typically their idea, right? It's typically the parents' idea. So I think a lot of work is done to engage them, to use sort of motivational strategies to help build commitment, to orient them to what CBT is, and to build commitment. And then what you're doing is you're working with them collaboratively to see what is important to them. So even if their goal is to get their mom off their back, right? They want to get their time back. So whatever way you can engage them, I think it has to be something they also want to accomplish. And some of the principles, of course, and the structure of CBT, it lands very well with them because they're used to structure, they're used to having homework. They actually don't object to that word because they understand that's how you build skills. I'll often tell them, right? If you go to a trainer and try to build your muscles, right? You can go to a trainer and then they can tell you what to do, but unless you're actually there pumping iron, you're not going to get better, right? You're not actually going to develop muscle. So they get it, in a way that this needs work. So I think once you're able to engage them, it can, and then, and then the therapy is very real, where you're not this sort of all-important therapist, which is, of course, the spirit of CBT in any case, right? You're this collaborative partner. I think it tends to go really well.
I think that gives us some kind of a strategy in entering that conversation. So that's really, really useful. Dr. Beck, I have a question from Alita, who's asking, can you briefly explain or summarize how a CBT session with a child would look like, a child perhaps younger than 10? What does that traditionally look like?
So that's not my specialty. So I think I need to hand that off to Dr. McGinn. Although I would like to say that I think it's really important when you have young children to figure out whom you should be speaking to. I think there are sometimes it's really the parents who just need some training and practice in parenting skills. Sometimes it's just the child, and often it's the two together.
Yeah, I would definitely add to that. And that is, depending on the age. So here at CBC, which is the practice that I founded, we treat kids with selective mutism, and here there are 3, 4, 5-year-olds that don't speak. So a lot of it is sort of getting down on the floor with them, cutting out pieces of paper, and writing, practicing sentences that they can speak. So it's sort of very basic exposure therapy. We have an OCD intensive where adolescents with OCD come in, and to what Dr. Beck was saying, which is that you do have to engage the parents. So we have a parent intervention. So they learn. There's actually a CBT intervention that was developed by Dr. Leibowitz, and that's called SPACE. So we offer that. The idea is that you're teaching parents how to support their child, but not support or accommodate to the anxiety or the OCD or the PTSD, right? How not to make it worse. So that intervention tends to work on itself, but then the adolescents are learning skills on how to overcome their anxiety about touching germs or just traditional CBT with them. Then we have something called parent-child interaction therapy, and that looks very different. And so that is for, I would say, between 2 and 7-year-olds, and there you are doing the therapy through the parent. So you could be you're basically in a separate room and you are watching the parents interact with their child. And through a microphone in their ear, you are teaching them CBT skills so that they are able to accomplish the therapy through the child, because at that point, they're very young. As they start to become 8, 9, 10, 11, then you tend to have kids more on their own, and you're still interacting with the parents. Once they become adolescents, then you have to make very clear guidelines on what you can discuss with the parents and what you can't discuss with the parents. But they're still very, very involved. In fact, I would say the young adults we're treating, the parents are still involved. And there it's a difficult balance where you have to now start to wean the parents off and yet keep them involved in their child's life. So
No, absolutely. And I think it's so nice to show those different development stages and
Yeah.
kind of what to expect. And I think, again, it empowers both a parent, a teacher, also knowing what to expect, what it looks like, what kind of therapies that you can try. And I love that it's not just one size fits all. It's so individual and it's really working collaboratively as a team. In Africa, we talk around our village, and it really just creates this village of people to raise a child, which is amazing. I must say, I'm really so encouraged by all of these amazing questions that are coming through. And I can just see we have so many different therapists that are joining and so eager for training in CBT and to learn more. And it just makes me so excited. And I'd like to, again, I cannot believe an hour has gone by so quickly. And, I would love to be able to stay on for hours more because there's so much to unpack. And I would like to take this opportunity to also talk about where these important conversations and these questions and these debates and discussions can extend at the upcoming CBTASA Congress that's happening at the end of August and beginning of September. And I'm going to bring in Daniel from CBTASA to come and share with us. But I can also share the exciting news to our audience, who are a mixture of different therapists and fields and sectors from around South Africa, is that these amazing guests are just a drop in the ocean as to the caliber of speakers that will be at the Congress. And both Dr. Judith Beck and Dr. McGinn will be at the Congress in person, which is really exciting, and really workshopping and having these discussions face to face, which makes it really, really exciting. Dr. Beck, maybe I can come to you before I come over to Daniel to tell us more about the Congress and what to expect and where to get more details. Is you're coming out to South Africa in Cape Town, coming to speak to all of us eager in the mental health space. What are you most looking forward to at the CBTASA Congress?
Well, I always really look forward to meeting people whom I either have known before or who are completely new, and finding out what people do, how they're applying CBT, what they see as the future of CBT, what problems they think that in South Africa, what problems do therapists encounter, how they solve those problems. So really just talking to people is my favorite thing.
I think there'll be a lot of talking, and I think there'll be a long queue just for you, Dr. Beck. Dr. McGinn, what are you hoping that, we're talking about paraprofessionals, professionals, we even have people who are joining us online right now from Zimbabwe. What are you hoping that the therapist takes away from the Congress, and what are you most looking forward to come the end of August?
Well, I'm looking forward to coming to Africa. So I'm looking forward to coming to Cape Town. I'm really excited about that. As Dr. Beck said, I'm looking forward to meeting people. And I would say that it's so exciting to me that this conference is happening. It's such a landmark conference. And I think that for therapists all across Africa who are able to come to this Congress, you are learning state-of-the-art CBT tools from experts around the world, as you mentioned. In addition, I think it allows it to spot.
Oh, sorry, Dr. McGinn. I think we've just lost you. I think it just went mute for some reason. Sorry,
okay.
We lost that important sentence.
Okay, I was saying that I'm excited to meet everybody, and I think it's also such a landmark conference, and the need in Africa is so vast and great, and it's such a beautiful, diverse continent, and there are so many different needs that I think coming to this conference, you're learning how to accommodate to those needs. So whether it is what is going on in Sudan in terms of the crisis there, learning psychological first aid to address the needs of people ultimately, or whether you're learning, CBT for anxiety or depression, I think you are coming to a Congress that is opening up the growth of CBT in Africa. And I think it is such a critical conference to come to and support. And I think it sheds the spotlight for it, even for governments, for schools, for agencies. So I think it's the place to be this August.
Definitely, and what a great segue. I'm going to bring in Daniel here because I feel like this is this is the place to come in. And I think, Daniel, welcome. Thank you so much for just coming, helping us to wrap up the conversation this evening. As we've all heard, we're really, really looking forward to the CBT-ASA Congress coming up. There's so much engagement and discussion. I can just see the chats happening. Can you give us a quick oversight as to what the Congress is about, who CBT-ASA is, and what's all happening?
I'm sorry, I have a patient, so I had to say goodbye. Thank you for inviting me today. Sorry.
Dr. Beck, thank you so much for your time. I so appreciate, and we'll see you in Cape Town in August.
Wonderful.
Looking forward to seeing you. Yeah,
Thank
and
you.
what a breath of fresh air to have the caliber of speakers that we have with Dr. Beck and Dr. McGinn. Cassie, also thank you so much for hosting us tonight and to start this kickoff of conversation. You know, I'm very excited we as CBT-ASA are very excited to be hosting the Congress. I think something that was very important that was said, which I just want to emphasize, is that this Congress is an opportunity to learn. Because if you haven't ever experienced CBT, or you haven't ever done anything in CBT, we're actually gearing this conference or Congress as a workshop learning experience. It's a workshop, it's not a talk shop. So obviously there will be presentations, but it's about giving people who've never heard about CBT the opportunity to attend really, really interesting and partake in really, really interesting learning. Learning opportunities, tutoring opportunities, where you get to have a one-on-one with experts in the field, and you're acquiring the skills yourselves. So that I mean, you can't expect to deliver skills to patients or to deliver skills to people if you don't know the skills yourselves. And we have a vast range of different types of CBTs that are going to happen at the conference. You know, we've got things like obviously we've got CBT itself, but we've also got amazing things like mindfulness that's going to happen. We've got things on DBT, and we've got things on ACT, and I mean, these are just these different generations of CBT, acceptance and commitment therapy, and we've got amazing different types of CBT applications that most people don't, you know, people just think about CBT as being formulaic, and you just apply it. But we're really encouraging everybody to come to the Congress and to really come with an open mind to learn, take part in a workshop. We've got amazing speakers that are coming to the Congress as well. You know, the amazing speakers are the likes of Dr. Shirley Reynolds, which is the Director of Psychosocial Interventions in the UK. And we have Dr. Paul Salkovskis, which is, he's renowned for panic work throughout the world. And of course, our very own Dr. Dan Stein, who's the head of psychiatry at UCT, and he's got vast amounts of experience in things like OCD and how do you help people with OCD? You know, people who are interested in helping their clients with OCD can learn directly from Dan Stein. And of course, you know, I can't forget some of the topics that Lata is going to be speaking about, which is universal prevention in youth as her keynote address, and also the CBT skills training for clinical conditions like trauma work and touching on anxiety and depression. So those are going to be very important topics that we're going to be able to cover in the Congress. And by the way, you don't need to be a mental health care professional who's registered, right? And that's a really important part too, because you heard what Dr. Beck was saying. This is now a really important point, is that we're trying to, in Africa, empower professionals or non-professionals to be able to deliver DBT, CBT, etc. We're empowering professionals and non-professionals alike. So, you know, whether you're an educator or a community worker or a peer worker, a pastoral counselor, an occupational therapist, a physio, or a social worker. You know, this is the opportunity for you to come along and to try out different kinds of ways of working with clients, and to learn new ways of working with clients. And the key word is evidence-based ways of working with clients, because, you know, we compare different groups and you see which ways work for clients and which ways don't work for clients. And we obviously, as people who want to help, we want to use ways that work. So
Absolutely.
please
And I
log
think-
on to the link in the description, and CBTASA 2024 and register in August 31. We're very excited to have you.
Absolutely. And Daniel, I just love the passion. And I think that's what makes it so exciting, is that everyone working in the space, it's having these rich conversations, bringing people in from different walks of life. I mean, we had a question this evening from Colleen, who's an emerging organizational psychologist. And I think just what you shared now on those practical tips, those discussions, those workshops that will be happening, is that everyone gets to get training. You all get to leave there rich with information. It's a jam-packed program with amazing speakers from around the world. And you've shared that link now where people can go and have a look as to the venue, the program, what to expect, the different practical workshops. And I think what's really exciting about the Congress is that it's so open to everyone getting involved. It's not restrictive. It's not working in silos. In the space of mental health, I'm really excited to see us breaking down those silos and having these big group discussions. We do have some more information as well on SADAG social media pages. Actually, an interview with you, Daniel, unpacking so much more around CBTASA Congress, what to expect, the program, what's happening, where and how. And I think it just shares, again, people giving the tips and the tools and the tricks of what to expect, how to get involved, so people can plan. And we hope to see so many different people coming out and engaging and growing this new CBT community, which I think is really exciting and I think inspiring that training. Dan, from your side, what do you hope? What is your biggest hope for the Congress and the outcome and these conversations? What is your hope?
Do you know that we've never, ever had a formal CBT Congress in our country? And this is the Cognitive Behavioral Therapy Association of South Africa is a relatively new association. We've only been going from 2019. So it's trying to bring together a network of people who are interested in the same kind of a modality and way of working. And so what we really hope to do is bring together conversations and form networks and really start to link up with international affiliates. You know, we're so excited to have formed relationships with the European Association of Behavioral Therapists and the World Congress of Behavioral Therapists, of which Lata is a president, and starting now to formalize these relationships. So the Congress hopefully will be the start of something that is unprecedented in our country. And this is all in the interests of serving our clients and the population of our country better. And not only in South Africa, but on the continent of Africa, making CBT more accessible and making CBT not only accessible, but also allowing us to do the application of CBT, making it more easily applicable to our population. So I've got so many hopes and dreams, and not only for what we can accomplish, but for myself too, because I'm looking forward to learning and growing and developing my skills. So I can't wait for myself.
Absolutely. I love what Dr. Beck mentioned earlier. You know, she's a better therapist today than she was 5 years ago, and that we should be better in 5 years. And I just love that growth mindset, which makes me really excited. I have to say, I'm so grateful for all of your time this evening, Dr. McGinn, in Dr. Beck's absence as well. And Daniel, just, you know, we're so excited about the Congress and having these ongoing conversations. SADAG have also partnered with CBTASA to run a series every single week as we're tackling new topics around CBT, the different techniques, the different therapies, the different mental health issues that it can assist. So please join us every Friday at 1 o'clock on our Facebook page, where we're tackling a weekly series up until the Congress. So we all get to continue learning and continue those conversations. So when everyone gets to the Congress, you're going to have long lists of questions and engagements that are happening. Dr. McGinn, I'm really looking forward to meeting you in person, and I'm going to come to you with your last words of wisdom as we're ending off our webinar this evening. What are your hopes for CBT, the Congress, the next steps in accessing mental health treatment?
I think as Daniel was saying earlier, and I think I mentioned as well, that this is a landmark meeting, because I think it is for the first of its kind. It's providing these practical tools and tips for therapists to take. And this is, of course, for the professionals and students and other health professionals and other paraprofessionals in South Africa, but also for other for people across the continent. So I know that as one of the key priorities I have as the president of the World Confederation of CBT is to really bring together people from all across Africa to this meeting so that we can have conversations. I think for me, the dream would be to really have CBT grow in the continent. You know, it is got so much opportunity, and there's so much work being done by so many people to help that growth, and for the world to see Africa as having a voice on the world stage, you know. So I think getting it out there, there's also a partnership. It's not just that experts are coming to Africa to teach, but I think it's also taking what people in Africa are doing and bringing it out. So my hope is that this partnership with Africa allows that interaction to start happening. And I think I'm really excited about that.
Sure. Daniel, no pressure after that. I mean, it's just, it's really exciting. And again, Dr. McGinn, thank you so much for your time and your insights.
Absolutely.
And everyone, please go have a look at the CBTASA 2024 website, and you can find out more about the program and the keynote address. To everyone that's joined us on Facebook and on Zoom, thank you so much for your interest and your questions and your engagement. We're trying to answer everything, but do follow us on our social media pages as well, and visit the websites, follow our updates on a weekly basis. This is just the start of the ongoing conversation. So have a wonderful evening and day. Thank you to everyone. We really look forward to seeing you in Cape Town at the end of August. Thank you.
See you then. Bye-bye.
Bye-bye.
Take care.